Good morning, everyone. Thanks for joining us this morning. We just are going to switch screens to get to our presentation.
Oops, sorry.
And then just for context, we have two laptops side by side, one because on Zoom, you can't have presenter view, it shows the entire thing. So that's why we'll be looking off to one side because that's where our presenter notes are. My name is Dr. Julie Doe.
And my name is Dr. Matt Markey-Krimp.
We are both resident physicians from the Swedish Cherry Hill Family Medicine Program. And today we'll be talking about value-based healthcare and specifically what clinicians need to know about it. Neither Dr. Markey-Krimp or I have any disclosures or conflicts of interest to report. And this is our general outline for our talk today. It is color-coded, and so we'll be walking through the definition of value-based healthcare, a little bit of the historical context behind value-based care. We'll give an overview of different payment and measurement types, and then we'll transition into talking about implementation, specifically at Swedish. We'll also be taking a look at a few different studies on providing evaluation and critiques of value-based healthcare, and then we'll start shifting towards thinking about a focus for the future and implications for healthcare equity. So we wanted to propose a kind of a little bit of a different version of a clinical case. It's really from the provider perspective to try to help illustrate our different components of our talk today. So our quote unquote case today is that you have a medically and socially complex patient and they're coming in for a follow-up visit with you in clinic. You think back to an email that you saw in your inbox a couple of weeks ago from your CMO saying that our health system overall is transitioning to value-based healthcare. And this is how we will be paid as providers. And we really start thinking to ourselves, what exactly are they talking about? So we'll start off with defining value-based healthcare. We drew from kind of two major sources to help define value-based healthcare. The first one from the New England Journal of Medicine. This is a healthcare delivery model where providers, including hospitals and doctors, are paid based on patient health outcomes. Sorry about that. And then from the Centers for Medicare and Medicaid Services, value-based healthcare is paying for healthcare services in a manner that directly links performance on cost, quality, and the patient's experience of care. So when we're trying to, good morning, when we're trying to define value-based healthcare, we'd probably think to ourselves, so what is value then? Dr. Michael Porter, he's a business economist and pioneer in the field of value-based healthcare. He defines value as health outcomes achieved per dollar spent. And so there's a little helpful illustration on the side here that shows you that patient values is equal to health outcomes compared to cost. And so what is the whole purpose of why we're even talking about value-based healthcare? Why is this important? So we're specifically talking about the shift from volume to value in the healthcare financing and delivery landscape, and really just thinking about how this is not going anywhere. This is where things are moving towards in the future in the United States. So in the past, the previous fee-for-service model had significant drawbacks, specifically financially and for the health of patients. So traditionally, fee-for-service payment had little to no emphasis on quality. Success in that context would equal profit or making more money, and the incentives were based on volume and the cost of care provided. We think value-based care is a really exciting opportunity to address both the concerns of out-of-control healthcare expenditures, as well as focusing on centering the health of the patient and patient outcomes. So on the right-hand side here, in value-based care, we're trying to pay for quality, prioritize the health of patients and positive health outcomes, and then thinking about success as spending less money to achieve better health. And the idea being, if we can keep our patients healthier overall and care for them really well, we end up spending less money on healthcare. And then the piece about having value-based healthcare here to stay. By 2025, 100% of CMS reimbursement will be tied to value. So we'll start taking a little bit of a different dive into thinking about where did value-based healthcare even come from, and why is it that we need to change how we get paid in healthcare. So this is a really simplified schematic or timeline. There are a lot of other points in history that are important, and so this is us distilling it to some major time points. So it's not a fully comprehensive timeline, but we'll just go over these major points. So starting on the left side here, in the late 1930s, employer-sponsored health plans began to emerge as an early form of managed care and insurance. Prior to that, you could imagine patients would pay for their health care out of pocket. Later in the 1950s, it was found that half of those greater than 65 years old were left uninsured because they were no longer working and not eligible for health plans through their employer. And so there were disproportionately high healthcare costs that then led to higher poverty rates for these folks, which really spurred the need for change. That second box there, in the 1960s, Medicare and Medicaid legislation was passed to address this gap, and it made the government a third-party payer. Moving on to the 1970s, the Health Maintenance Organization Act was passed, and this solidified the managed care model through HMOs and PPOs. So Health Maintenance Organization, to help define that a little bit, it's an integrated healthcare delivery and financing model. Members pay a fixed monthly fee for a group of healthcare services and then are restricted to in-network providers and hospitals. PPO, or preferred provider organizations, offered a little bit of greater flexibility in the choice of provider, and there were financial incentives that existed for patients to select in-network providers to get care from. And so managed care aimed to control healthcare expenditures and control costs through concepts such as capitated payment. We'll go into that a little bit later. Quality of care and utilization reviews, and patient financial incentives to use in-network providers. This brings us to the early 2000s, where something called the managed care backlash happened and kind of slowed the growth of HMOs just a little bit. Americans were really dissatisfied with the way that managed care reduced healthcare costs. And so a couple of different examples to illustrate this. So different employers could put employees into a single managed care plan without offering another choice. And so that took some autonomy away from the patient. There was a little bit of contention around the requirement that a patient had to be seen by a PCP to then access specialty care. From the healthcare side, the idea being that you are not utilizing specialty services inappropriately, and if you have a referral, then that would be able to kind of control costs of utilizing specialty care. But from a patient perspective, it was another barrier. You can also imagine that if your health insurance changed, people who used to be in network are no longer in network for you, and they're considered out of network. And so that could be really a big barrier as well and challenge. And then HMOs did rapidly grow. And so there were some instances of inconsistent coverage decisions, lags in claims and paperwork processing. Sometimes there was delegation of decision-making to individuals without the adequate training or experience. And so, and no access to like comprehensive algorithms that now exist today to help make those coverage decisions. And so there was a lot of emotional fallout. And then there were HMO horror stories in the press, as you can imagine, where people were being essentially being denied care or being denied coverage for care. And so in the background, this graph is from the Kaiser Family Foundation, but this is showing us that over time, by 2023, at the far right of the screen in that big red arrow, the national health expenditures as a share of GDP is going to be greater than 20%. And so this really just illustrates the need to continue to look for ways to curb healthcare spending. And the current ongoing movement, though it is slow and sure, is value-based healthcare. So to set the stage a little bit for value-based healthcare, in 2007, the Institute for Healthcare Improvement began creating the triple aim. This is a framework that's now used to optimize healthcare systems based upon a few different tenets. So improving patient experience of care, including quality and satisfaction, improving the health of populations, reducing the per capita cost of healthcare, and then the expanding to a quadruple aim or a fourth aim, improving clinician experience. Clinician satisfaction and preventing burnout. This triple aim and later quadruple aim became a foundational basis for the Affordable Care Act, which we will go into next. So the ACA was passed in 2010 and continued to focus on value-based healthcare delivery to expand the use of paying for performance in Medicare. The Centers for Medicare and Medicaid Innovation was created. The role of CMMI is to test, evaluate, and expand in all the different Medicare and Medicaid programs, as well as be able to test the different payment structures and methodologies to reduce expenditures while maintaining and improving quality of care. Through the creation of CMMI and the Affordable Care Act, CMS gained greater authority to reform payment structures based upon value. And these are called alternative payment models. There are a lot of different versions of APMs or alternative payment models, and I'll just go through some of them here. Bundled payments is essentially paying a predetermined amount for an episode of care, whether this be surgery or labor and delivery, and it requires providers to assume risk for covering costs that go above that target price or target budget. But it also means providers can share in the savings if you spend less money than the predetermined amount. Hospital value-based purchasing includes incentive payments for quality. So for example, if you reduce or eliminate adverse events, adopt evidence-based standard and protocols to achieve best outcomes, improve patient experience, et cetera. An accountable care organization is a voluntary program where a group of providers, hospitals, clinics enter contracts with CMS to provide care to Medicare patients, and there are financial incentives if they meet quality standards. So we will now pivot a little bit and think about payment and measurement types. And so you can imagine from a clinician standpoint, you're thinking to yourself, what are these quality measures? Where did they come from? And what are the different types of payment that exist? So we'll define those different payment types first. On the far left-hand side here, fee for service. This is a long-standing traditional way that healthcare is paid for. You make more money if you increase the volume of services. So for our clinic visit for a patient from the very beginning, if they come in for an office visit, they could be charged for the labs that we order, any imaging we order, and the office visit itself. In the middle here, we'll talk about capitation payment. This is introduced when managed care emerged as a way to control healthcare costs. It's a set amount of money paid per patient per unit time. So you can share, or you can save money if what you end up doing for the patient undershoots that set amount. And the predetermined rates depend on the range of services provided, the number of patients involved, and the period of time during which the services are provided. And so they come up with these set amounts through local costs and looking at average utilization of services. So for example, perhaps a healthcare plan or a payer pays $100,000 for an entire year of healthcare services for a patient, specifically for preventive care. And then this last part on the right-hand side, value-based payment, also known as pay for performance. This is based upon different measures of quality, which we will discuss in detail pretty soon here. So how do we measure quality? Dr. Avedis Donabedian, he is a physician and founder on the study of quality in healthcare and medical outcomes. He essentially proposed a model to examine the quality of care that are based on 3 different types of components. So structure, process, and outcome. This triad is really meant to be a guide rather than a requirement or a straitjacket, as he says in one of his articles. It's really hard to get reality to align completely within these categories, and all three measures are indirectly measuring quality as they influence healthcare, which then influences health status. So a structural quality measure assesses the environment of care. We have to, there's a baseline assumption that the characteristics of a healthcare delivery system has significant impact on quality of care. It can increase or decrease the probability of good performance and a positive health outcome. And so a couple of different components that can fall under a structural quality measure: the facility itself, the staff, and the resources that the staff have access to. One example of a structural quality measure could be a staff to patient ratio. Next is a process quality measure. This one takes a look at the performance of activities that have been demonstrated to contribute to a positive health outcome for a patient. This one is focusing on steps that should be followed to provide good health care. There needs to be a scientific basis for the process, and if executed well, the process increases the probability of achieving a desired outcome for a patient. And so an example of this would be the percent of people receiving recommended cancer screening. And then an outcome quality measure takes a look at the impact of the healthcare service or intervention on the health status of the patient. This seems to be the quote unquote gold standard for measuring quality, but it's a little bit controversial in favor of performance because the outcome rests on many factors, many of which could be outside of the provider's control. So for example, if you had complication rates from a surgery, there may be components specific to that patient's health illness health story that are outside of the surgeon's control. There are some risk adjustment models that exist to help account for those factors, but these are ever evolving. And one example of an outcome quality measure could be surgical mortality rates. And then a separate concept from Donabedian's original triad, but it's also related in a growing topic, is patient-reported outcome measures. So this assesses the patient's perception of quality of the care that they received and their satisfaction with the care experience. For example, whether or not explanations of care were easy to understand, or in a different example, the level of physical function achieved after a joint replacement. And so we know that there's an inherent subjectiveness that can make it complicated and hard to measure. How are these quality measures implemented? The CQMC, or Core Quality Measures Collaborative, is a public and private multi-stakeholder effort amongst CMS, different healthcare plans, the National Quality Forum, even national physician organizations, including the AAFP. They're working to define core measure sets for various specialties. The CQMC defines a good quality measure to encompass importance, being scientifically sound or producing consistent and credible results, and feasibility. So that is one group that is trying to determine valid performance measures to actually use and implement. The National Committee for Quality Assurance also has created the Healthcare Effectiveness Data and Information Set, or HEDIS measures. HEDIS measures how well health plans give service and care to their members, and then the health plans can collect that data about performance on certain services and types of care. So for example, how many kids receive immunizations. They then report that data to the NCQA, which rates the health plans on different measures across different areas of care. And then essentially these measures are all used to track healthcare system performance and identify opportunities to improve patient care. However, I would say that the bottom line truly is that there's an overall consensus and alignment that needs to be achieved across groups in order to implement standard measures. Not all payers adopt and implement the same quality measures. And CMS and some private health plans have actually committed to phasing in the core measure sets from CQMC over time, but really their effort is actually trying to get alignment across all the different payer groups. And then just as an aside, I was walking into the hospital this morning and we have a 5-star quality rating at Swedish Cherry Hill. CMS also uses like a star quality rating system to measure the experiences of Medicare beneficiaries that they have with their health plan. And so you can be rated from 1 to 5 stars, 5 being the highest. And there are quality metrics that are used to determine that.
Great. So I think we're going to take a little look at how these sorts of things are implemented here at our home institution at Swedish Medical Center. I did want to mention that all the info, or most of the info in this section, was per a conversation that I had with Renee Rassleter-Bomers, who is Swedish's Chief Quality Officer, and I really appreciate her taking the time to talk with me about what's going on here at Swedish. So going back to our clinician case here, say that you're rotating on the inpatient service next week at Swedish, and thinking about quality metrics, kind of what sorts of metrics are they tracking there, and then why does Swedish care about this? So what you see here is a screenshot of the Swedish Medical Center's quality dashboard. This is a tool measuring some of the quality metrics that Swedish has decided to prioritize, divided by the quadruple aim, as you can see in that top line in blue: patient experience, health outcomes, stewardship, and caregiver engagement. The black line in each box is a 24-month average of where the quality metric has been, while the light gray that you see in the back there demonstrates month-to-month trends. Swedish has set a goal for each of these quality metrics, and we can see where the hospital is in terms of that goal by the red or green shading. Most of this data comes directly from the hospital EMR, while some, such as the data around caregiver engagement and workplace attrition, comes from HR and some other sources. You can also further stratify the hospital campus, you can stratify the data by hospital campus by clicking on those buttons on the top there. I think it's actually really important to notice that this dashboard is actually internally transparent, so anybody on the Swedish intranet can access it, including Swedish employees. Just kind of talking with Renee about where these specific quality measures come from. She mentioned that they are informed by the larger Providence St. Joseph strategic priorities, with some adaptations made for how Swedish does things here. They're not directly influenced by the large payers like CMS and private health insurance, but most likely represent kind of an amalgam of some of the priorities of the organization and of insurance companies themselves. So kind of going into the business case for Swedish, why does Swedish care? I think being able to show data and hopefully increase quality of care is where our payment system is moving, kind of like what Julie was mentioning earlier. So this diagram on the right, I thought, was a interesting conceptualization of how payment tied to quality, kind of where that's going. And this is from a quality group white paper. So on the left, we have complete fee for service, the old model, category 1. Category 2 in red here has conceptualization of a link to quality and value on a fee for service basis, such as kind of those value-based payments that Julie was talking about, incentive payments for meeting certain quality benchmarks. Going on to category 3, that's a broad application of these advanced payment methods, or APMs, like we were mentioning earlier as well, such as capitation and bundled payments overlying the fee for service basis. So all this is still based on that fee for service structure there. Finally, category 4, which this diagram calls population-based payment and sometimes is known as global payment, envisions a system where healthcare systems are paid a set amount for a certain population of patients, as well as for quality care of those those patients as well. Sort of a larger scale version of capitation and pay for performance. In this system, health systems are paid a certain amount for the population patients and are able to pocket that savings if they're able to be more efficient and reduce the cost of services the patients need. Alternately, like we mentioned earlier, if they spend more than they budgeted on the population of patients, they take on that extra cost. This also includes bonuses for high patient quality of care that are intended as a way to disincentivize rationing of care. Some health systems that have attempted to take that on were those ACOs that Julie mentioned earlier. And then kind of going to Swedish, I think it kind of may seem like we're moving there slowly. I think this is where we're moving. So as we mentioned earlier, 100% of CMS reimbursement will be tied to value by 2025. And private insurance companies are kind of moving there as well. I'd say that we're probably we're still living kind of in a category 2 world right now, but Swedish is trying to look forward to the future when we're moving up towards more of that population-based payment. I think Renee also mentioned during our conversation that focusing on quality makes sense from a competitive business standpoint as well. So Swedish is actually competing for patients in an increasingly consolidated healthcare market here in Seattle and Washington more largely. What business people call these sentinel moves, these large business moves are kind of changing that landscape. For instance, the recent CHI Virginia-based merger, Kaiser Permanente continuing to offer kind of this novel integrated insurance and health system approach, and multi-care buying up some hospitals in the South Sound have all pushed Swedish to at least think about quality as a way to attract patients to our system. So we'll move on a couple more times here to take a look at evaluation and critique of value-based healthcare. So if you're a clinician, you might think, how do I know that any of this is going to translate into better health for my patients, kind of what we care about as clinicians, and not just more documentation for me, which has often happened. What does the medical literature say about value-based healthcare? So I'll attempt to answer our hypothetical clinicians question by focusing on one large study and mentioning a few others and a few other studies in the literature. One of the larger, more recent studies I found was by Song et al., published in 2019 in the New England Journal. This was a prospective, non-randomized cohort trial that followed a large population of patients who enrolled in a subset of Blue Cross Blue Shield private insurance called an Alternative Quality Contract, or AQC. The AQC was an early form of an ACO, or accountable care organization, which we mentioned earlier. But again, that's an organization where healthcare providers come together to take on financial responsibility for a group of patients, as I mentioned earlier. This study followed enrollees in this program and evaluated the per capita cost to the system per patient, as well as any differences in preset quality measures. These were measured against a control group of patients enrolled in private health insurance plans in other surrounding states in New England. This study was based in Massachusetts. Different cohorts were tracked, with the oldest cohort, the 2009 cohort, having 613,000 patients and 1 million controls. They tracked cohorts by year, so the oldest cohort is 2009, looking forward for 8 years. I should note that while the study was funded by the NIH, Dr. Safran, the third author here, did start working for Blue Cross halfway through the study, creating a possible conflict of interest. So, looking at results from the study, Figure 1 here shows the evolution of the average annual healthcare spending per enrollee in the oldest 2009 cohort on the y-axis here. So that's average annual spending per enrollee. With the year on the x-axis. The blue line represents the 2009 AQC cohort, or the ACO, while the dotted line represents the average annual spending for Blue Cross Blue Shield patients in Massachusetts. So it's notable to say that they were not able to separate out the AQC cohort from the larger Blue Cross Blue Shield patient population. The red line represents the control group from the different states. Again, these are controls that are enrolled in private health insurance in different states. So as you can see, around 2016, those lines diverged. The study noted an average reduced spending per enrollee of $461 versus control states, which represented an 11.7 relative savings on claims, which was statistically significant. I should note, though, the 2011 and 2012 cohort showed something similar, while the 2010 cohorts did not show a statistical savings. The authors kind of mused that this could be due to not enough data over time, or due to the fact that the patient population was smaller actually in that 2010 cohort. The savings was mostly attributed to less care utilization, including fewer ED visits, less lab testing, and less radiologic study ordering. Now take a look at the quality data from that same 2009 AQC cohort. So the study looked at multiple different measures to see if there was any improvement or decrease in quality, perhaps through underordering or underutilization of care. The y-axis counts the percent of patients meeting these quality metrics, while the x-axis looks at years. So this is kind of a complicated slide with a few pains in here, so I'll go through them one by one. So Pane A looks at an amalgam of chronic disease measurements, quality measures for metabolic syndrome on the top. So there are two graphs here. There's the metabolic syndrome with the solid line, and then depression quality measures lower with the dotted line. The blue lines represent the 2009 AQC cohort, while the brown lines represent the New England control population, and the green, the overall national average for this quality metric. You can see that there isn't much difference in the populations for the depression measure here, while there does seem to be an increase in the amount of patients meeting quality metrics for metabolic syndrome there at the top. Similar results can be seen for overall adult preventative care and pediatric preventative care. That's for adults in Pane B and pediatric in Pane C. These include things like cancer screenings and vaccinations. All the different quality measures were reported by the authors in an appendix. In Pane D, they looked at what they call outcome measures for hemoglobin A1C and hypertension, with similar results favoring the AQC. So these results certainly seem to favor the AQC group, and certainly don't seem to indicate that patients were receiving worse quality care in the AQC group. I do have a few reservations about the study. Controls were not in the same state as the intervention population, and the savings were not seen across all years cohorts, like I mentioned earlier. In looking at quality metrics, the study did not provide a way to see if these differences were statistically significant, so there was no p-value, or merely kind of a variation on normal. And I'd argue that for Pane D, these outcome measures they mentioned here, hemoglobin A1C and controlled hypertension are really actually still more correctly labeled process measures, whereas a true outcome measure would be more something like mortality or incidence of acute coronary syndrome. I think nevertheless, though, Song's paper does perhaps give us a glimpse into the possibilities of value-based care, both for savings and quality of care for patients. I'm just going to mention a few other studies that I got that I looked through the literature, and just kind of to say really like I was kind of looking for a consensus about value-based care, and there just currently isn't one right now. So in Yu's paper, they looked at bundle payments through Medicare, and they found that they don't seem to affect quality metrics, and they may reduce payer spending, but don't necessarily reduce absolute spending, so the total spending on patients. In Navath's paper in 2021, they looked at a combination of ACO enrollment status and bundle payments. So those were two kind of alternate payment methods. The combination of those decreased medical spending, but not surgical spending, and were associated with a small reduction in readmission rates, but that was like less than 1%, 0.7 to 0.8%. In the Mendelsohn study in 2016, that was a systemic review showing pay for performance was not linked to improved patient health outcomes, though it wasn't limited by poor quality studies and heterogeneity. I'll just also mention some compelling critiques of value-based healthcare. These are all kind of arguments that are published in major medical journals, and I think are worth mentioning. Starting with our own good Dr. Saver, and I promise that this is actually quite a good article, not just because he's our faculty member. Saver et al. in 2015 made an argument that most of the measurements used are process measurements, kind of similar to the measurements that I talked about in the Song paper. There is little evidence that these process measurements actually lead to differences in health outcomes. There's no long-term studies saying that improving process measurements leads to better outcome measurements. He also argued that measurements taken, the measurements that we are able to measure are often the ones that are most easily measured and not the ones that are actually patient-centered and that matter to our patients. In Montori's article in 2019, they argue that industrial healthcare is putting more of our measurements and documentation on both patients and clinicians. So I think talking about that documentation burden and how the healthcare system requiring measurements is really sort of more a function of it wanting the measurements more so than increasing patient satisfaction or increasing patient value, and argue that we should kind of redefine value in terms of how it matters to patients. I think Teesberg also argued the same thing. So I think increasing focus on those patient-reported outcome measures, and if healthcare actually help the patient feel better. So I think kind of recentering the patient in our thoughts about quality measures, and saying, well, if my grandmother doesn't like really just wants to be more mobile and see her grandkids and doesn't really care about what her hemoglobin A1C is, maybe that's something that we should be paying attention to, as opposed to just trying to track down every single little measure about her. And then finally, a study put out by a systematic review put out by the RAND Corporation in 2017 really underscored the fact that there isn't really a definition of what a high-performing healthcare organization actually is. So I think with all this, it's kind of tempting to say, well, we don't really have any data about this, so why should we even pursue this in the first place? I think what I'd say is we don't want to throw the baby out with the bathwater. The medical evidence is mixed, but this is just a really hard thing to study. So there's due to the heterogeneity of payers, the length of time needed to detect a change in patient outcomes, and then just the amount of variables going into every one of these measures as well. So I think in the American healthcare system, we don't really have like a consistent system, and people change payers so frequently that I think it's hard to kind of detect a long-term trend unless, say, everyone is on the same system, or we were all kind of consistently using these same measures. I also think the devil is in the details in terms of patient outcomes and how things are paid. I think these are incredibly complex systems, and I think, at least for myself as a provider, I wanted to look into this because I didn't understand how this worked, and I think the fact that our payments, our system is so opaque, and I think it really demands that we engage in the system, because I think this is where things are moving, just like Julia was saying, and I think we need to educate ourselves and engage and figure out what is going on a local level. So finally, for our last section, we're going to talk about some implications for health equity, and not to add more aims, but the Institute for Healthcare Improvement, or the IHI, has actually been talking about maybe adding health equity and healthcare equity as the fifth aim on top of our other quadruple aims. So as a clinician, you might ask, my patients are majority BIPOC, underserved. How do I know that this push for quality isn't going to leave them out? And what are some ways that I can advocate for my patients receiving the same to receive the same high quality health care as white and well-resourced patients? Talking about value-based healthcare and health equity, there has been a large amount of advocacy around using value-based care as a possible vehicle for actually addressing health and healthcare inequity, and kind of specifically looking at using quality metrics as a way to hold health systems accountable for providing very, very often unequal, unequitable care for patients. I think this is underscored, though, because a lot of QI projects in the past have attempted to maybe kind of a rising tide raises all boats in terms of improving the healthcare system for everyone, and thus desiring to kind of increase or decrease health disparities. But time and time again, that's been shown to not close disparities. So kind of widely targeted QI programs do not do that. There there have been some moves in terms of the large organizations that we talked about. For instance, the NCQA has developed an equity roadmap for individual institutions to use to implement interventions, but there hasn't been any large-scale quality incentives targeted at equity by CMS or any of the larger payers. There was kind of an interesting effort early in 2011 by the Massachusetts Medicaid, excuse me, to reduce health disparities by targeted pay-for-performance metrics targeted at health inequity and disparities. Unfortunately, that didn't show any real difference at 10 years, but I think on retrospect, it was hampered by kind of this one-size-fits-all approach, and the learning there was the interventions need to be tailored to the local population. To just make this a little bit more concrete, I thought I'd kind of mention some things that we can do as clinicians, and things that are kind of some exciting ways that value-based healthcare could target health inequity. So our patients are sick, they're underserved, and they're victims of structural racism. And I think we need to know how to represent this in our charting and in our advocacy for payers and health systems. So I think a big way to do this is representing how complex our patients are, both in their healthcare and in their lives. I think historically, people don't want to take care of BIPOC patients and underserved patients because they're hard to take care of, and a lot of work because of all those historical reasons that I mentioned earlier. I think one of the ways that payers have strived to address this would be things like more accurate medical coding representing complexity. So I think you may have heard of the HCC code, that stands for Hierarchical Condition Category, which was developed by CMS in 2004. It uses codes associated with a certain ICD-10 code as well as demographics to create what's called a risk-adjusted factor, or an RAF, which kind of is part of that calculus that increases payment to our systems and our clinics. I think this is a great way to just like a low-hanging fruit to make sure that CMS knows that we're dealing with really sick patients who need a lot of care, and I think I just kind of repeat what we've learned recently in our residency through coding. The coding actually can be advocacy for our patients. I mentioned there's something, I was just listening to this in a SDFM conference talking about geographic risk adjustment. So using things like a zip code to adjust the complexity of the population in terms of payment. So just as we think of zip code helping determine your health status because of things like redlining and because of things like just historically underserved parts of the country, I think they're thinking about using that as a way to bring more resources to those communities. And then finally, thinking about this idea of performance improvement versus performance metrics. So performance metrics are kind of a yes or no thing. So you get your patient's hemoglobin A1C down to below 7, whereas performance improvement is the idea of rewarding improvement on the metrics. So we know that decreasing hemoglobin A1C from 14 to 10 would provide a large cardiovascular risk reduction, but you won't get that payment in a performance metric system. A performance improvement system would reward you and your patient for that step, even if it's not kind of the perfect goal or to 7 like that. This could also kind of address sort of a common critique, which would be kind of cherry picking patients that are really close to the goal, focusing on them. So like trying to get a person from 7.5 down to 7. And then finally, I think just what does an institutional commitment to health equity and quality look like? I really think Swedish and in our region with their with a increasing focus on diversity, equity, inclusion has an opportunity to be on the cutting edge of measuring quality in our populations that we serve. So I think one example of this is Massachusetts General Hospital publishes their annual report on equity and healthcare quality. So this is a large document that they've been publishing for 12 years that actually stratifies their quality data based on race and ethnicity, and they go through it line by line and actually enumerate which interventions specifically that they're using to try to close those health disparities on a local level for their system. There's nothing like this in our area. I think talking with Renee, there's been some talk about trying to really bring out that data, but I think having some transparency about this, like, really will provide show the rest of the health systems in our area and our patients and our providers that that Swedish has a commitment to closing these health inequities in our system, starting with us. I think a good example of this that I discussed with Renee was the Black Birth Project at Swedish, which was spearheaded by some data, some patient-reported outcome data, which was from Black moms and Black parents saying that Swedish didn't respect Black birth, and I think the Black Birth Project, which mobilizes Black doulas to take care of our patients, was a directed response to that, and I would love to see more of that going forward. So we made it to the end. Our take-home points here. Value-based care is a movement to associate healthcare delivery with quality in order to achieve the triple aim or quadruple aim or quintuple aim. Quality metrics can be structural, process, and outcome-based, and can be reported from the healthcare side or the patient side. Critiques of the system exist, including the idea that it does little to directly address health inequity. Institutional level change in leadership is required to address healthcare inequity on a local level. And value-based care is not going anywhere, and it's critical that clinicians continue to build their knowledge base in order to contribute their voice and our voices. Thank you so much for coming to our talk. We are open for questions. It looks like we got some here. Looks like we got a lively discussion here in the chat.
In paragraph format.
I expected nothing less from Dr. Saber. Let's see, let's go to the top here. From Alston, under the capitation payment, were there any policies in place to prevent practices from cherry picking healthier patients? Looks like Barry answered that. Let's see. Yeah, I think in terms of, I think previously that was one of the big, like Julie talked about the HMO backlash. I think that was one of the big critiques of HMOs, is that there wasn't anything in place for, like, I mean, before the ACA, you could just deny a patient healthcare, right? Because they were a sick person and had pre-existing conditions. So like, I think that was a big thing. I think things like quality payments and some like payments associated with quality are designed to try to counteract that and give payers more money if they accept sicker patients and they can improve their health outcomes.
Right, and then the next one is Dr. Saber making a point that HEDIS was sorry, scroll down. There was a name change in HEDIS. It was truly, it was originally the Health Employer Data and Information Set, and so it was a rebranding. There's some HCC adjustments for those experiencing being unhoused. Yep.
Dr. Doe says, I've inherited patients fired by their previous PCPs for non-compliance due to regular life stresses some patients have. Yes, totally.
Or disabled THAT who refuse general placement until they get a weight below 200 pounds, quit smoking at least for 6 months. And that's about surgeon quality outcomes and not patient-centered outcomes.
Yeah.
Good point.
Yeah. And then Barry makes the point that readmission rates devoid of context say very little. Not many interventions have successfully reduced readmissions and reducing needed ones and not improving quality. And I think that's it. I think that's something that Barry we talked about earlier, and kind of like which of these quality measures are actually useful quality measures, and like which actually reflect increase in patient health versus just trying to decrease healthcare utilization. But if you need to get readmitted, you need to get readmitted.
Yes, and then Dr. Gu really makes a great point. Value-based healthcare is extremely complicated. The devil truly is in the details, and that these studies are trying to illustrate for us that failures are showing us how not to do something.
Mm-hmm. Dr. Kovar, do you find studies that suggest dumping of patients with poor quality metrics, persistently poor A1Cs, or high ED utilization? Yeah, I think that's a good point. Like I think there was nothing that I came across in my lit review that did suggest that. I think that would be a pretty hard thing to capture and measure, though. However, I do think that there are. I mean, all these payment systems are pretty complex, and it's hard to parse that out all the times. But in many payment systems, there are things in place that reward you for keeping the same patients on the plan for longer, I believe. And then Dr. Saber responded to that. And then, yeah, Dr. Gu was talking about risk adjustment movement for getting increase in payment for more complex patients that require more care. How is Swedish changing their physician payment? Has that been worked out yet? That is a great question, Dr. Doe. I think one thing we were thinking about doing was Shannon Waterman was thinking about sending us kind of the current SMG contract, which does include some value measures. I think that is pretty. And then Dr. Gu says they're about to roll out a new payment contract, but they. Those, I think the thing to remember is usually there isn't kind of a direct line between what quality measures the insurance companies want, what quality measures a hospital wants, and which ones that physicians are paid on, right? So I think you won't get paid on like 15 different quality measures. There might just be 3 or 4. But I think so I think kind of like
speaks to that the need for alignment across.
Yeah. So like those are not always aligned, and that might be part of what's what needs to change in the system.
Yep, and then true, SMG is still mostly on fee-for-service plans.
Yeah, that's right. So kind of talking about like we're still back in that category 2 based on that fee-for-service architecture.
Any other thoughts, questions, or comments? You can also feel free to unmute yourselves.
I hope you can do that. Oh no, you can't actually
Oh, they
unmute.
can't actually unmute.
Okay, stick those questions in the chat then.
Oh, that's true.
We won't take it personally, Alice, I promise.
I was like, we'll just sit in our quiet
I know.
one-sided conversation.
Yeah.
Apparently, you can only unmute panelists. So if we wanted this to be the Dr. Barry Saver and Dr. Shannon Waterman show, it could happen.
I do really appreciate the kind of spirited discussion that we were having in the chat during the entire talk too. I do think it speaks to, I don't know, I think this is a very, very complicated but also very important conversation to have, and I think the more education that we have as doctors and clinicians about this, the better.
I know I was thinking about future directions after putting on this Grand Rounds talk, and I didn't get a chance to meet with the CMO or other leadership at ICHS specifically about how value-based healthcare is being implemented at our continuity clinic, but I think that would be a really great next step for me personally in my growth on this journey about learning more.
Yeah.
It's just trying to figure out what is actually happening at home.
Yeah, absolutely. Dr. Roach, PMG is docs talking about, can you charge, for example, $30K for taking vacation? Be careful about signing value-based contracts moving forward. Oh, thanks for the advice. I think yeah, definitely something we're thinking about is burgeoning attendance here in the next year, and looking at contract negotiations for us as well. Cool.
Sounds like the Seattle Science Foundation will be sending out an email with the link to a recording of our talk. And then Corey Kepler, who's been extremely helpful from the Seattle Science Foundation, kind of our tech person as well, sent out a way to claim CME credit for coming to this talk.
Great. Well, we really appreciate everyone listening, and hope the discussion will continue going forward. Please reach out to us if you want to keep talking.